Hello, everybody. I'm Dr. Shelley Hall. I'm the Chief of Transplant and Advanced Heart Failure at Baylor University Medical Center in Dallas, Texas. I'm so sorry I couldn't be with you, but I was asked to speak on the crash and burn patient to ECMO, and I hope that you find my comments useful. So a lot to go over. I'm just going to kind of briefly summarize ECMO and in particular ECPR, which is what we're talking about for the crash and burn patient. What comprises an ECPR program, how to build one or start one, how to select patients to use this therapy, and then ultimately you have to prepare for what's going to follow. So we'll start with ECMO, and it's important to understand and remember that ECMO is essentially cardiopulmonary bypass taken out of the OR, stripped down a little bit, and used to support a patient for an extensive period of time. Now, in a nutshell, ECMO is a fantastic tool. It gives complete body flow. You can take care of everything. It doesn't matter what's wrong with the heart. You can add oxygen if the lungs are bad. You're going to rapidly decrease your preload as you're pulling blood out of the right atrium. You can do this bedside with no imaging, which is very important in a CPR situation. And you can dialyze off the circuit. And you can see the marked changes in arterial perfusion pressure rising, but also notice one of the biggest pitfalls, and that is the increase in LV afterload. And you can see there's a marked increase in LV afterload. And this results in increased myocardial oxygen consumption because you're making the heart work harder against this afterload. Obviously, these are big cannulas, and so there's issues technically with that. Distal perfusion protection is standard of care now when you're placing ECMO cannulas. Very high complication rates. You often need to unload the left ventricle in some methodology, either medically or mechanically. You need a lot of additional expertise that's not available in all ICUs. And we are ultimately talking about applying this very complicated treatment to the sickest of patients, what we call the SCI stage E. And so no matter what the reason, this is some data from recently from the cardiogenic shock working group, no matter what the reason for their shock, whether it be they presented as SCI stage E, they worsened to E, whatever, we're talking about looking in the red anywhere from a baseline 50% mortality up front. So what I want to emphasize with that is people are going to say, oh, cardiogenic shock patients are like this, and you throw them on ECMO and they're going to be brand new. But the reality is that the sick ECR patient, this is what they are. They are a crash and burn patient. And the majority of them are going to end up like this. And I think that's really important to understand up front what patient population we're dealing with and outcomes, because it's important for the mindset of the team. This is a psychologically draining group of patients. So going into an ECPR program itself, it is absolutely a team sport. Just the physician team alone, you need cardiothoracic surgery, trauma surgery, or critical care, often emergency medicine's involved, vascular surgeons for protection devices, cardiology, either interventional, heart failure, or both, pulmonary critical care members, depending on how your ICUs are organized, and anesthesia. And ultimately, these patients are going to be everywhere in your hospital. So every department has to have some experience or understanding of what's involved in ECPR, from your emergency rooms to your cath labs, your operating rooms to your ICUs, everywhere on your hospital campus. These patients can drop outside of an outpatient office waiting room, outside, trying to get into the ED, anywhere. And then I put pre-hospital there because if you get to the point where you're doing this at a decent volume, you're going to start to go out to patients and put them on ECMO and bring them back. So next is the equipment. It requires a lot of preparation. These are our ECMO carts that are prepped with all the equipment that we have a guideline in place. You see here the ECMO insertion cart lists all of the equipment that should be inside. And then this cart has to be able to fit on all appropriate elevators to get anywhere in your hospital. These on the right are the prepped and ready ECMO circuits. And these are rolled to wherever the patient is, and the patients are cannulated at that site in an ECPR situation. Ultimately is that they are filled with protocols, and these are protocols for just about everything. When you're ready to build an eCPR program, the first step is laying out your algorithms and getting these in easy, digestible methodologies where people can visualize them. You can create posters and templates to put up. This is showing kind of when it's coming through the, if somebody feels that there's medical CPR ongoing, either from an EMS or somewhere else, and a code is called, then they'll assess and determine code ECMO versus the standard ACLS, and on and on. This is a diagram of how the team should be laid out. And just for reference, RT is the respiratory tech, ultrasound machines, RN on both sides of the patient. C is for cannula. So one's got the arterial and one's got the venous, and then A is assistant. So this is a two-person and two-assistant job in a well-organized eCPR team. This is a team lead. This is the ECMO specialist with the ECMO cart. There's a pharmacist or somebody dealing with the drugs, and there's an electronic RN, somebody who's tracking everything. This is a basic layout called the Mayo table of what an eCPR team, and I'll show you some pictures. We actually throw these labels onto people. They're all gowned up. You don't know who is who, and we'll slap these big labels on them so that you know what they're doing. Training in sim labs is crucial to getting good performance. And these are just snapshots from our sim labs where there's didactic and hands-on training with dummies. And so these are greatly attended sims, but it's a lot of practice because there's absolute chaos, sensation, and energy when it's happening for real. This is actually the screen cam when this is a patient brought in from EMS, brought in on a thumper, and this is one of our trauma bays. So all of our trauma bays have cameras and it's all recorded, and so you can see oversight and how people are setting up. After this is done, we review all these cases. Here's a recording from one. Hopefully you can hear this. And so you can see the label on there. It says RN in bright red, and then you can see there, I think that's an assist or an airway, I couldn't tell. And so there's a checklist we call 10 and 10 for here. These are the 10 things we want to get done in 10 minutes in evaluating whether we should go ahead and to then be connected. So when you've got these patients, how are you selecting these patients for eCPR? So these are considered the ideal strategies. I just want to comment a little bit about each. Obviously, we're talking about adults here. And the recommendation is 18 to 70. But what's magic about 70? Why not 65 or 75? And so 70 is a loose number. I mean, you could roll into a patient undergoing a code and they look 50 and it turns out they're 72. And you could roll in and go, they look 90 and they're 50. So, that visual, what we call the eyeball test and that overall protoplasm assessment is an important component, not just the digital age. Witnessed arrest is the next one. Well, yeah, witness, but what does that mean? Somebody saw them go down. So it was EMS. It was, family. It was in the hospital, out of the hospital. How do we define those criteria for witnessed arrest? Immediate CPR. Well, what does that mean? 5 minutes since they went down? 10 minutes since they went down? What if you don't know? What if they were hypothermic? Does that matter? So these are these generic terms on the left, when you start to try and create protocols for, become a lot less clear. Is it a shockable rhythm? Well, yeah, it's great if it's VTVF, but what if it's PA? They're hypothermic or they were hyperkalemic or something and it's PA. I mean, PA is theoretically a reversible rhythm if you can find the cause, so why not? So the shockable rhythm thing is a little debated. Their history about the patient is very important. Do they already have a DNR? Do they have multi-organ dysfunction? Do they have a terminal prognosis? Do they have terrible vasculature that you're not going to be able to easily access? These things are important. Unfortunately, you don't always have the luxury of knowing anything about the patient in an eCPR situation. And then the etiology is do you know what the etiology is of their arrest, such that if you support the body, are you going to be able to reverse the cardiac situation in some way that made it worth going through all this? So our criteria that are on our protocol, again, generic, none of these, they're all considered general guidelines. It's not like if you put an ECPR on a 71-year-old, you're going to lose your privileges or something. So witness sudden arrest, unless hypothermic, then we'll give them much longer time than witnessed. If we find them frozen, we don't have that too much in Texas, but we do have a few every year. Age under 70, no prohibitive comorbidities, no return of spontaneous circulation. Obviously, if you've resuscitated them appropriately, you don't need to do ECPR. BMI less than 40, that's sometimes not easy to tell by eyeball. A potential reversible etiology and hypothermia-induced VF. Those are general criteria. Specifically, if they're in the hospital for us, if they're having acute coronary syndrome and they have potential to go to the cath lab or OR, we're going to ECMO them because we were planning to do something for that heart. If they're in the cath lab or in the OR when this happens, we've already committed to them for that procedure or surgery. We're going to ECMO them if it's feasible. If they're post-op, those procedures, same thing. Exclusions, where the neurological prognosis is poor, if they're very large, there's no realistic reversal of the cardiac condition expected, very advanced ages, they already have a DNR, they have severe bleeding disorders, severe peripheral vascular disease, they've had a stroke recently, you can't anticoagulate them, known severe chronic organ disease already, and then we have some hard stop criteria. And this is about the only hard stop we have. And that is marked hypoxemia. If their PO2 is under 50, their SAT's under 75 for a prolonged period of time, if their lactate's over 16, pH under 6.9, base excess more than 14 millimoles, these are all hard stops. I will tell you that there's no such thing in medicine as a hard stop, pretty much. If this is a 20-year-old hypothermic, they're going to get on ECMO. But, you know, if it's one of these, but everything else is great, they're probably going to get on ECMO. So it's still, although these are hard criteria we look at, there are certainly exceptions that have happened. Ultimately, if you're doing an ECPR program, you got to also be prepared for the what after. So when that adrenaline settles in that case, what are the patient needs and what are the program goals are the two big things that you have to address afterwards. So under the patient, you first got to have expertise in managing the complications. Remember, this doesn't treat the heart. It actually hurts the heart with the increased afterload, and venting is often needed in more than 50% of the time. This running picture shows clot formation in the aorta because the heart's not ejecting. There's no blood circulating. It's all just getting retrogradely pushed, and so clots can rapidly form in the aortic arch or aortic root if the LV is not contracting. And then, of course, all the mechanical complications that can occur with ECMO, you've got to have strategies in place to manage. Manage the prognosis. Are they recoverable or not? And if it moves on forward and they're not, having good palliative support programs to help the families and the care teams through this. You put a lot of energy into trying to save somebody and then it didn't go well. They've had a big head bleed, or their leg is ischemic and they're going to lose it, or their heart remains at standstill. These are tough things for the families and for the care teams to go through. Making sure that expectations are very realistic and everybody understands that we're dealing up front right away 50% mortality in all comers. And then manage the destination. If they don't recover, are there exit strategies? And that means really for the heart, right? So that's, are they a chronic inotrope candidate? Can they bridge to inotropes? Or are they a VAD or transplant candidate? And if none of those are really possible, then if they're not in a recoverable situation, then you're talking about withdrawal. And you have to have strategies and teams ready for those conversations. And the reason this is such a big deal is because now ECMO does have an exit strategy. They can be transplanted with a new allocation, and they're listed in status 1, and they don't have to wait months and months behind everybody else. They have a shot. And as a result, we are seeing more ECMO utilization as a bridge to transplant. And this shows the waiting times with the new allocation. You can see they were ridiculous waiting times, 150 mean days. Nobody's going to survive on ECMO that long, VA ECMO. But with the new allocation, we're now talking just a matter of a few days. So if they're otherwise a good candidate, they have an exit strategy now. And as a result, we are seeing a rise in VA ECMO as a bridge to transplant, about 100 cases a year now, where it was literally 20 to 40 previously. And when you look at before, these people would be evaluated for VAD because they couldn't survive long enough to a heart. And now in the new era, most of the risk factors favor transplant. So the only ones that somewhat favor LVADs but cross the center line is age over 60 and a BMI over 30. And maybe some renal dysfunction. But again, that's pretty soft. You can see it's not really statistically significant. So overall now, what you're seeing is no ECMO to LVAD anymore. It's ECMO to transplant, recovery, or death. And this is not impacting in a bad way. In the old system, you could see that the ECMO patients rapidly died on the wait list. They were mostly removed for death. And now they're markedly removed for getting a successful transplant. So here it shows that in the old system, their days for listing, they were more likely to die. And now they're more likely to get a heart transplant. And the outcomes are better. So at least in the short term, 180 days, if you got transplanted on an ECMO, you had a not so great, 180-day survival here, right? Hits your statistics pretty bad. Now, pretty darn good survival in the short term, which is really where their risk is, the post-operative recovery. So ECMO to transplant is now viable in appropriately selected patients. Obviously, as a program, your goal is survival, whether that's survival with their own heart or something else. And as I showed you, our first survivors reunion, we have a post-ECMO discharge clinic to follow them because there can be chronic other things going on with them from the treatment. And then growth. As I mentioned, one of the things, if you start an ECPR program, an ECMO program, you're going to ultimately start to travel outside of your hospital to other places that don't have that resource and try and help some of those patients. So overall, I think it's important to know that ECMO saves lives on a daily basis, that it requires a very experienced, committed, multidisciplinary team, a lot of resources, a lot of dedication. You're taking the highest risk procedure, ECPR, to the highest risk patient, and you need to know that up front. But it can be a very vital service to your patients and your community if done well. And with that, I'm open for questions.